All right. Well, thanks to everybody for coming. I have a couple slides going up there just to review what we're going to be talking about today. But I really just wanted to say thank you to everybody who's here today. I think a huge thanks to Daisuke for helping put this program together, and Asagi Soto and Joshi Shin for being the administrative support to really help nail down all the logistics. Just an absolutely huge help. We have an international faculty for this meeting again from Sweden, Japan, Switzerland, Norway, and the U.S. And so really a solid group of people from all around. And that's what makes this meeting really special. And we had a really wonderful symposium yesterday with ISHA where we partnered with ISHA and just very, very well received. And so we're getting a lot of momentum with SciMeg's relationship with others. So we're going to keep that going. Some reminders for today. We have a full, robust agenda for today with a lot of different speakers, a tight timeline. So I would ask that all of our speakers stay on time, and I'll get up close to the end of your talk as a gentle reminder to stay on time. So with that, I think we'll go ahead and get started with the agenda, and I'll turn it over to Dr. Kurosawa.
Thank you very much to joining us today. So I'm very happy to have Sakura joint expert today. So we get started this program. So actually today there are no chairman because this is a very small group. So I hope. Everyone voluntarily raise their hand and to ask something to the presenters. Woodie, now we are going to start. Thank you very much for coming. In the beginning, as an introduction, Dr. Woodie Cross will talk about that. Okay, so I'd like to start this conference. Unfortunately, I must begin with very sad news. Our great manager, Mr. Michael Dix, passed away on August 7th this year. Together with Dr. Volker Fuchs, he founded our group, SciMeg, with a very strong passion, and he dedicated his life to our activities and until the very end. At the kind suggestion of our president, Dr. Woodie Cross, we chose to name our award in his honor. As Dr. Jeff Donner commented, Michael generously donated a good part of his life and energy to keep SciMeg alive. Thanks to his dedicated commitment, SciMeg continues today, and we can all together here. We are profoundly grateful. Dankeschön, Michael. We will never forget you. So everyone, may I ask you to stand and. Let us observe a moment of silence in the memory of Michael Dix. Thank you. Please be seated. Also, we started with a sad memory. Let us move to a moment of celebration to honor the great work of Professor Murakami. He's a recipient of the Michael Dix Lifetime Achievement Awards this time. Now let me briefly introduce my mentor, Professor H. Murakami. He is a leading pioneer of the sacroiliac joint SIJ research in Japan. He founded the Japanese Sacroiliac Joint Research Society in 2009 In 2010, he opened the first sacroiliac joint center in Japan, and of course in Asian area. Now, so he has been served the director of the International Sacroiliac Joint Research Institute in a hospital from 2025. I myself have been working under his guidance since 2009, conducting spine surgery and SIJ clinical research with him for 16 years. When Professor Murakami first presented his work on the SIJ 30 years ago, he faced a storm of criticisms and had very few supporters. But yet he never gave up. By the time I joined him, all the arrows direct to the sacroiliac joint and to the Dr. Murakami had already been taken, and I was able to conduct sacroiliac joint research in a very comfortable environment. Thank you, my mentor, Dr. Murakami. So he published many papers, both in Japanese and in English. In particular, he has published regarding the diagnosis, physical findings on sacroiliac joint. These are very important papers guiding to the development of SIJ practice in Japan and expanding its influence to the Asian countries. Professor Murakami has written 4 books, one of them in English. When it comes to the sacroiliac joint, no one else can talk about it with such deep knowledge and experiences. To summarize the achievement of Professor Murakami, these things, he will talk about these things in the later, next to his presentation. I'd like to say that he is serious in his academic work and continue to pursue truth with strong passion. I believe that he's a true specialist of the sacroiliac joint, and he is fully deserving of this award. Congratulations, Dr. Murakami. So, I'd like to, please. This is a plaque to the honor this prize. Thank you. Congratulations. Congratulations. So now Professor Murakami will deliver his lecture, a review of my 30 years of sacroiliac joint research, development of diagnosis and treatment for the sacroiliac joint. Okay, Dr. Murakami, please come to you.
Thank you for presenting me this award. I would like to talk about my 30 years of sacroiliac joint research. Senda City, 300 kilometers northeast from Tokyo, low back pain and sacroiliac joint found 2010. International Sacroiliac Joint Research Institute founded with Mr. Sanaka, Android robot maker. My first patient with SI joint pain. In 1995, I met a woman with severe gluteal and leg pain. Could not sit on a chair, not lay on her back, not respond to any injections, including epidural block, selective nerve root block. No any idea about injecting into SI joint. Without expectations, I tried SI joint injection. Surprisingly, immediately severe pain diminished. For the first time, I noticed the existence of SI joint pain. Since then, I have researched SI joint pain for 30 years. At the beginning of my research, common knowledge in modern medicine, SI joint is immobile, not provocate pain, not. SI joint is immobile and worthless. I tried to prove that SI joint moves. Measure of movement in SI joint. Senior instructor of AKA Hakata method tried to move SI joint. Before and after operating, CT imaging was performed and compared. Using the method of Professor Inoue, degree of accuracy 0.2 degree, 0.1 millimeter. As a result, anterior rotation 1.5 degree, translation 1.6 millimeter. Really, SI joint moved. Movement of SI joint during pedal walking with Toyohara and Professor Ohashi, Hokkaido University Faculty of Engineering, and Professor Hama, Medical University of Graz. And as a result, maximum deformation of SI joint, stance phase 0.6 millimeter, swing phase 0.3 millimeter. And as you know, pelvic incidence value, the angle formed by the perpendicular line from the center of the top of the surface of the sacrum to the center of the femoral head. PI value being considered as eigenvalue changed after spinal fixation. These are also indicated. Position of ilium to sacrum was changed. Namely, SI joint is moving. My strategy for recognition of SI joint pain, due to no finding on the image SI joint pain, is easily ignored. For recognition, it is extremely important to demonstrate the indispensability of SI joint in human body. Is SI joint actually necessary in human body? Without SI joint, the human body cannot function well. From evolution, quadrupeds in horse, ilium connects to spine. Posterior leg was changed to lower limb in human body. SI joint is the junction between the trunk and the lower limbs. Important role of SI joint supports the upper body and absorbs shock from the lower limb. It is better that SI joint do not move for the supporting body weight, but not move. But SI joint shouldn't move too much. But shock absorption is impossible without movement of SI joint. Why does SI joint enable this? Key is in the specific movement of SI joint. SI joint, seismic isolation device for the human body. Unique movement of SI joint. It hardens the moment you touch it. Joint static reflex. While continuing to apply a small force, it starts moving slowly like a snail. Joint dynamic reflex. This movement is similar to seismic isolation device. After accepting the load, gradually start moving shock absorption. Seismic isolation device damper, seismic isolation rubber. This is a similar movement. Due to the existence of many joints like the SI joint in the human body, a child can jump out of a tree and run away without getting hurt. SI joint, key station for standing balance. As a child grows, the center of gravity moves to the anterior of SI joint. In adult, GC and to anterior of SI joint. It has been proven that body will hold before brain command arrives at the conduction species of nerve systems by inverted pendulum experiment. To avoid a falling incline, fast shift of gravity line is necessary. The quickest way to move the gravity line is to rotate the pelvic, post-pelvic fast gravity line is fast shift is possible. SI joint where information are concentrated from the trunk and the lower limb is controllable of pelvic movement. SI joint is a key station for standing balance. Neck states bird rely on sensory organs in the lumbosacral region for balance during walking. SI joint is prone to dysfunction. Main muscle to move lower limb originate from pelvic bones. Trunk and lower limbs move independently. Because trunk and lower limb move independently, SI joint is constantly exposed to shearing force. Responding to large load with a small range of motion, joint misalignment is likely to occur. By joint misalignment, pain occurs as an alarm. Sudden onset, acute low back pain. Persistent onset, chronic low back pain. A major obstacle in SI joint pain, difficult to diagnose. Two types of SI joint injection, intra-articular injection, peri-articular injection. Intra-articular injection is the gold standard in the diagnosis of SI joint pain, but low success rate. Brodsky, only 20%. Difficult and not familiar for general physician and spine surgeon. Further, diagnostic rate is also low. Difficulty and low diagnostic rate of intra-articular injection. Recognition of SI joint pain has been made difficult. At one time, I noticed, I tried intra-articular injection, but failed. But reluctantly performed injection into peri-articular region was effective. I developed peri-articular injection. Divide the peri-articular area of SI joint into 4 sections, injection into the section with positive provocation test. Success rate under fluoroscopy is almost 100%. Very easy. SI joint pain originates from peri-articular region. intra-articular injection and peri-articular injection compared. Many nociceptor and pain-induced substance around the sacroiliac joint. Compared, intra-articular injection is effective 36%. 64% peri-articular injection is effective. In about 2/3 cases, SI joint pain originates from peri-articular region. Recent data for typical SI joint pain with gluteal pain and PSRS are indicated by one finger test. In 18% of patients, peri-articular injection was effective. Only 20% of patients required additional intra-articular injection. Why? Diagnostic rate by intra-articular injection is low. Intra-articular injection cannot block pain from pain-articular region. SI joint pain thrive from intra-articular 1 and peri-articular region 2. But intra-articular injection only block 1. Consequently, intra-articular injection cannot diagnose pain from 2 peri-articular region. And then intra-articular injection no rate is very low. Technical aspect of SI joint injection. Technique, peri-injection easy, intra difficult, success rate, intra-articular injection low, and bedside injection, peri-articular injection possible, intra-articular injection impossible, need fluoroscopic guide. Peri-articular injection, SI joint block have become popular in Japan because peri-articular injection can be performed easily at the bedside. Strategy for SI joint pain, first, peri-articular injection. If necessary, intra-articular injection should be added. This algorithm is efficient to diagnose SI joint pain. Contribution of Japan, SI joint pain. Technically difficult and low diagnosis rate intra-articular injection is gold standard and difficult to diagnose. But in many cases, technically easy peri-articular injection is effective. By peri-articular injection, SI joint pain easy to diagnose. Further challenge, easy to detect SI joint pain, develop one finger test to identify accurate pain area. Patient with SI joint pain point to red circled area on and or within 2 centimeters from the PSRS as the main site of pain by one finger test. One finger test, SI Japan, if you point here, 85% is SI joint pain. SI joint pain is easy to detect. And superior cranial nerve entrampment, this site is point one finger test. Notice, one finger test is different from 14 finger test. 14 finger test is a specialized test to identify SI joint pain and derived from intra-articular origin. But one finger test can be used to identify various buttock pain, SI joint pain, superior cranial pain, superior gluteal nerve pain, sacrotuberous ligament pain. one finger test is appropriate for diagnosing SI joint pain, often derived from periarticular origin. Our criteria for the SI joint pain, low back or buttock pain on the overs of SI joint. Positive finding on at least one out of SI joint shared test, Gensler Patrick. But more than 70% pain relief after injection into the SI joint. Diagnostic process of typical SI joint pain, identify pain area with one finger test. 2, positive provocation test. We prefer SI joint sharing test. And more than 70% pain relief after injection. Further challenge, sacroiliac joint score. Japanese Sacroiliac Joint Research Society, 6 centers collaborative research, developing score, distinguish between lumbar spine disease and SI joint disorder. Japanese society evaluating 10 times item to distinguish between SIGD and LDH, SS. Out of the 10 items, gluteal pain at PSIS with one finger test, groin pain, STL on the tenderness, is 3 items significantly higher in patients with SIGD than those with LDH and LSS. Specific pain area to SI joint, gluteal pain at PSIS, and groin pain, and ischial tuberosity. Sacroiliac joint score, total Q point. PSIS by one finger test, 3 points. Groin pain, 2 points. Sitting pain, 1 point. SI joint share test, 1 point. Tenderness, PSI, SL, 1 point respectively. Hold up. Differentiation of general lumbar and gluteal pain. A cutoff score of 5 points. Sensitivity, 77.4%. Specificity, 76.4%. Tonus to article. Diagnostic algorithm for SIGD in Japan. Physical examination, reference to SI joint score, and provocation test. Next, diagnostic injection. At first, periarticular injection. More than 70 pain reduction, definite diagnosis. Not next, intra-articular injection. Pain reduction, more than 70%, yes, definite diagnosis. Or both injection not effective, the other disease. Further challenge to relieve severe SI joint pain, develop the anterior fusion of SI joint pain, extraperitoneal approach. Sitting time and walking time improved significantly. And furthermore, decreasing abduction from flexion of hip joint after SI joint fusion. As a result, 10 to 20 degrees of hip joint movement depend on movement of SI joint. Challenge for popularization. SI joint seminar has been held 18 times. From the third seminar was held at Jaiko Sendai Hospital with a small number of participants in 2006. Since 2009, I have been working closely with Dr. Kurosawa, who participated in the 5th seminar. 17th seminar in Sendai. content lecture, free talking with a patient, learn diagnostic technique, bedside block or endoscopic block training. To date, approximately 150 orthopedic surgeons, neurosurgeons, and peg clinicians have participated in the seminar, spreading diagnosis and blocking technique throughout Japan. Let's establish national organizations. Pioneering the world, SI Joint Research Society was established in Japan from 2009 years. The Japanese Sacroiliac Joint Research Society established with 7 executive members in 2009. Dr. Murakami, Dr. Yoshida, Dr. Abe, Dr. Is, Dr. Ozawa, Dr. Kato, Dr. Musha, Secretary Dr. Kurosawa. Research meetings have held on a year since 2010. Free talking with the patient has received treatment was planned since the first meeting. Participant by orthopedic surgeon, neurosurgeon, pain clinician, general internal medicine, and physical therapist. The holding research meeting, a total of 302 patient participants. The number of participants has increased with each meeting. National-wide awareness is spreading through both seminar and research meetings. By President Ayumi Kaneuchi, Professor Kanazawa Medical University, next week, the 16th meetings will be held in Toyama. Publish of books. Sacroiliac joint pain in Japanese, 21, so the first edition, the 2024 second edition. English books was also published. Sacroiliac joint disorder, accurately diagnosed low back pain from Springer Curtis. 10 years, Masahiro Yasuoka, a great scholar of Oriental studies. 10 years is great. 20 years is fearsome. 30 years will make history. Thank you for your attention.
Extra-articular injection, but not the intra-articular injection, does that change the way that you treat them? And should we change the way we treat patients based upon which injection they respond best to?
I'd like to say, sure. Instead of him, so he would like to say that the pain origin of the sacroiliac joint is more frequent around the joint, particularly for posterior ligamentous lesion, because of the nerve ending. There is a very many nerve endings is reached around the joint capsule, not in the articular lesion. So as a gold standard, we believe that the sacroiliac joint pain may come from the intra-articular area, but he found that the true pain origin is located in around the joint, particularly for posterior ligamentous lesion. So that now, if the patient have effectiveness of intra-articular injection, I prefer to fuse the joint. But in the beginning, to find the pain origin. We use the periarticular injection for diagnosis of SIJ pain. So
The reason I ask that question is because usually when I choose surgery for a patient, it's based upon the response to a perfectly placed intra-articular injection. If they don't respond to that, then I'm typically not offering them surgery. When they get injections in the extra-articular space or a periarticular injection, I don't fuse those patients often, and I'm wondering maybe I should change what I'm doing based upon the results. So, thank you.
Thank you, Woodie. So actually, we performed the sacral joint fusion surgery after diagnosing using periarticular SIJ injection. This patient can recover. This patient recovered well, so it's very feasible to use periarticular injection to making the decision for SIJ fusion surgery. Are there any questions? Please come here.
So I just wanted to clarify, when you said you had successful extra-articular injections confirmed, what do you mean? You had contrast in the extra-articular space, or you just showed that the needle was in those areas?
じゃあ、so instead of him, I would like to answer. So,
最初の頃はもう造影剤使って確認してた。
so he used a mixture of local anesthetics and contrast medium. Contrast medium mixed. So 1% or 2% lidocaine and contrast medium, and he confirmed the local anesthetics is limited in the ligamentous region. So and in addition to that, I confirmed the contrast medium within the ligamentous region by CT scan. So as a research. So
Follow-up question. So is that something you see with ultrasound or the dye, or do you have to use the X-ray after?
now we use ultrasound guided, and so we can check the local anesthetics limited in the ligamentous region by using the ultrasound. Yes, so but in the beginning we use fluoroscopy guidance, and so that we use contrast medium and local anesthetic mixtures. Yes, confirm. Yes.
And then I got a lot of questions, but one more, if you don't mind. One, come on. Come on. Thank you. So when you do extra-articular injections, you're also doing dorsal rami blocks. So you're anesthetizing the entire joint, almost like when you're medial branch block, you know, the dorsal pain nerves. When you do those multiple injections, it's not just ligaments, you're actually, anesthetizing. You're anesthetizing the whole joint. Presumably, there may be some anterior component. So it sounds like it's more of a global SI and, anesthetic diagnostic than it's specific to the extra-articular. Yes or no?
人体のブロックと枝のブロックでは人体のブロックが効くっていうことがデータとしてある。
So it is difficult to translate. So he would like to say that we have evidence that injection into the ligamentous region is more effective than the nerve branch block to the sacral joint. So yes. Yeah, please.
First question. How many patients have you operated with anterior fusion? How many patients have you operated?
Have you operated? 何人でしたっけ? 27? So you mean that how many patients did he
Operation.
anterior?
Yeah. Around 50. What is the result? Everybody happy?
75%.
75% are happy. Okay. Complication?
Complication.
Yes or no?
Paresthesia.
Yeah.
Stage of the lateral side
Yeah.
and the weakness of the iliopsoas muscle.
Okay.
Also, pubic symphysis is the pain.
Pain in the pubic symphysis.
After bilateral anterior excitation,
Yeah.
the patient are easy to complain of.
Okay. You did hear that? Yeah. Okay. Thank you. I think it's time now.
村上先生、宇都宮と言います。おめでとうございます。日本人です。日本クロス先生が固定をされても股関節の可動域は減らないっていうふうに教えてくださったんです。そこが違うので、ちょっとそこを質問させてもらいたいと思います。クロス先生は仙腸関節を固定しても股関節の可動域は減らないって僕に教えてくださったんですよ。だから何か違うのかっていうことを今から質問したいと思います。So Dr. Cross told me that if the patient got the SI joint fixation, but they don't lose the range of motion of the hip, but the result of Dr. Murakami, it was different from Dr. Cross's result. So I'm wondering what is the difference between the two results. So is it the difference of the fixation method or so Dr. Murakami is trying to fix the patient with a periarticular pathology, but you are trying to focus on the SI joint itself. What is the difference between the two result?
10度から20度っていうのは最終的に仙腸関節の動きによって担保されているんで、なんでおそらくそこを止めると間違いなく股関節に影響は出てくると思います。ただそれがすぐに結果として出てくるかどうかわかんないけど、もうロングタイムではおそらく影響出てくると思います。
Dr. Murakami mentioned that so full range of motion of the hip is 120 or something like that, and including the 120, 10 to 20 degrees are affected by the SI joint movement. So Professor Murakami believes that fixing the SI joint brings the result of loss of the range of motion every single time. How do you think about it?
Do you think that's a result of the surgical approach? I think similar to Thomas's, because I haven't had that experience with the way that I fuse the SI joints, and I usually see my patients more mobile because they have dramatically less pain. And so I'm wondering with the anterior-based approaches, if you're getting some psoas scarring or iliacus scarring from the surgical procedure, which results in a loss of range of motion.
So I think it's possible.
Yeah.
Yeah. 僕仙腸関節っていう名前を使うことによってフォーカスが関節そのものに行ってしまっていることが問題で、もしペリアーティクラーの話もされましたけど、そこをもっとコンプレックスとして広げていただけると我々股関節外科医も入っていきやすいので、そういったことを今ちょっと申し上げようと思うんですけど、So as Professor Murakami mentioned that periarticular injection works for more than 80% of the patient with SI joint trouble. So that means this is not the trouble of joint itself, but the complex trouble. So I think that so some physiotherapists say that the name terminology of joint is misleading. So maybe it's better to think not only the joint cartilage itself, but the complex lesion, considering not only joint, but also nerve, as you told, or the soft tissue, muscle insertion, everything would be very nice to include. Then I am a joint surgeon, hip joint surgeon, and we are easy to jump in to the SI joint complex. This is how do you think?
Yeah, I fully agree. Yes, yeah, and I do think that it's posterior buttocks pain. It's the whole complex. It is not just the SI joint. It's there must be 5 to 10 diagnoses around the SI joint, which can all be problematic, and that's why we're here.
Okay, so, thank you very much for very good questions from audience. Okay, so thank you very much for the great presenting for Dr. Murakami.